Welcome back to Taking Charge of My Cancer podcast, episode 58. Joining with me today is Dr. Mustafa Ahmed, and I'm not sure if I say it right. He's passionate about helping heart failure patients author their own story, and he's honored to be part of such an amazing team here at UF Health. He's an associate professor at the University of Florida Division of Cardiovascular Medicine. He specialized in advanced heart failure, ventricular assist device, and transplantation, while serving as the section chief of heart failure and medical director of the Mechanical Circulatory Support Program at UF Health. He wears many hats, including the program director of the Cardiovascular Disease Fellowship here at UF. He attended Johns Hopkins University as undergrad and obtained his medical degree at West Virginia University School of Medicine, where he was awarded the Liere Research Scholarship and the Harak Dedhia Medical Student Award. Thereafter, he completed his internship and residence at Thomas Jefferson University. He started his training in cardiovascular medicine at UF, followed by an additional fellowship in advanced heart failure and transplantation while serving as the Cardiovascular Source Therapy Research Network training scholar. Certified by the American Board of Internal Medicine in Cardiovascular Disease, as well as advanced heart failure and transplant cardiology. His current research interests include stem cell therapy in heart failure, ideal strategies for pacemakers and defibrillators and LVAD recipients, interventions to reduce bleeding in LVAD patients, and the role of spirituality in medical care. He also stayed engaged as a member of the Heart Failure Society of America, as well as the International Society for Heart and Lung Transplantation. Within Gainesville, he's actively engaged in the community, having founded an expense-free medical clinic that received recognition by the annual Spirit of Gainesville Award in Medicine. And in his free time, I'm sure it's not that much free time, he enjoys reading fiction, grilling, playing and watching sports, and riding his bicycle. So I'm really, really impressed with you, Dr. Mustafa, and thank you so much for being with me tonight.
Thank you so much for having me.
Absolutely. So you want to tell me a little bit about your role and if you always were planning to do this?
So I think sort of as I got interested in medicine, one of the things I really enjoyed was having long-term relationships with my patients. And that kind of drew me towards cardiology, and within cardiology was really enjoyed interacting with heart failure patients. And so certainly since I've been attracted to medicine, heart failure was something that I was really drawn to.
Mm-hmm. Wow. This is something that I think can be like what I see it from the rehab standpoint. When we see some of the like the lung and cardiac transplant patients in here actually for some cardiopulm. So this is like, a very, ill population, right? So they can be really stages where you can really make this huge difference, or the curve can go completely the opposite.
Exactly.
How do you manage that? You know how sometimes it's like we want to help to the patients, but, dealing with that, like, well, no, actually it's nothing I can do for that.
I think, oftentimes that too is a service that you're providing a patient and the patient's family, and certainly for the physicians who might be referring that patient to you, to let them know that, everything's been done, and, every thoughtful intervention that could be offered has been offered. And I think that sometimes helps people feel, maybe that they've done the right thing. Certainly can help a referring provider, and can oftentimes help a patient or patient family have some closure as it relates to how they've gone through their disease journey.
Got you. So I was thinking a lot about you just because I had a patient and we were talking about cardiotoxicity, and I have the fortune to actually sit in one of the cardio-oncology kind of like annual meetings that you guys do about maybe 2 years ago. And I was so fascinated by all the maybe trials and that you guys were talking about. How can we really try to protect the heart in the middle of all these chemotherapy drugs that can be very bad for the heart? So that's kind of what I kind of reached out to you, and I was so excited that this patient was already seeing you to try to really start to create, I don't know if I want to call it prevention, but how can we protect the heart, So you want to try to tell us a little bit about, how exactly that works?
Yeah, so oftentimes chemotherapeutic agents can have other toxicities, and as it relates to the heart, the one that people are most concerned about is developing a syndrome of weak squeezing function of the heart. And that is usually related to the effects of the chemotherapy on the heart muscle itself. And so what we try to do is try to prevent that from happening as opposed to treating it once that becomes manifest. And so there are a few different ways to do that. There are some new research trials that have shown that cholesterol medications can help prevent that particular toxicity. And it's likely related to the fact that cholesterol medications, in particular the statin medications, have a lot of anti-inflammatory and antioxidant effects at the level of the heart muscle. And so that then allows us to think, okay, well, there's other medications that have those types of effects at the level of the heart muscle. Could they also be helpful? So it's an area of very active research to try to come up with the right combination of therapies that can prevent these types of complications, which not only can cause patients discomfort, but also can sometimes lead to their chemotherapy being stopped intermittently or sometimes even stopped altogether. And so I think oftentimes the role for the cardio-oncologist is to think, how can we facilitate the best treatment for the cancer? And what steps do we need to do to protect the heart or improve the heart function to allow that?
Got you. When is that happening? Is that happening is every patient with cancer who is having some of that cardiotoxicity with those chemo drugs will come to you? It's like an automatic referral. It is somebody who already have some previous, comorbidities with the heart, or how is that process go?
So it's a combination, a little bit of both. Sometimes our oncology colleagues who are seeing a patient who has a lot of cardiovascular disease already, maybe they don't have heart failure, but they have a lot of risk factors, they might send us that patient up front to get some sort of a risk assessment and maybe come up with a combination of therapies to help prevent the complication. Then certainly on the back end, we get a lot of referrals as well for patients who have developed some cardiotoxicity for whatever reason. And then we're trying to come up with a pathway to help mitigate the impact of that to allow them to get more chemotherapy.
Got you. How about the
Kind of a
patients?
mix of both.
Okay, got you. How about patients who have no cardiovascular risk? Is that something that you like, if I'm like healthy and I'm gonna go through all this chemo, can I just say, I wanted to try to prevent my heart to get damaged?
Yeah.
Is any role on that?
So I think that, that's a good conversation for someone to have with their oncologist.
Okay.
And to ask specifically, hey, do you think I should be on one of these cholesterol medications based on the type of chemotherapy I'm getting?
Okay.
We do not see every single patient prior to getting chemotherapy. Some of that is related to, this is not a complication that happens to everybody. And so it's not, and certainly getting diagnosed with cancer and going through all the treatments, this is already a very large emotional burden on someone. It's also a physical burden to go to all these different appointments.
Yeah.
And so it's adding an additional an appointment, adding an additional concern for every single patient who goes through that. That might not be the best use of resources, and it might actually impact patients negatively by causing more emotional burden and more time burden. And so I think that we still have to figure out what's the best way to do that. It's
Okay.
probably most useful for individuals who do have a lot of risk factors and already have cardiovascular disease.
I got you. And then how often, like on the trials and the results of those trials, how would you kind of give us a little bit of like what kind of outcomes are you seeing with those patients? Like, is there really a percentage? I mean, what are the results on that?
Yeah, so there's a very significant reduction in the risk of developing chemotherapy-induced cardiomyopathy with a certain type of chemotherapy for patients who are getting treated for breast cancer. And so, I think that, for individuals who are getting started on anthracyclines for breast cancer therapy, and particularly for those who are then are subsequently going to be on anti-HER2 therapy, so things like trastuzumab and pertuzumab. I think it would be a good idea to utilize a cholesterol medication, a statin medication upfront, provided somebody doesn't have a reason why they absolutely can't take that medication. They're generally well tolerated. They don't affect blood pressure. They don't affect heart rate. And they can, they've proven to be effective at preventing the complication. And so I think that those are the individuals who should be started on that, particularly if they have risk factors for heart failure. So if they have high blood pressure, or in the past they've had high cholesterol, or they have other risk factors for heart disease, like being heavier or being very sedentary. I think those are the individuals in whom we could really impact care by doing that.
Okay, great. And for how long usually are they taking those medications? Is during the course of chemotherapy? It's like, yes, as soon chemotherapy is done, they just done with that, or they just continue going with that?
So we don't have any good, answer to that. And so generally speaking, I would continue sort of cardioprotective therapies throughout the duration of chemotherapy and for some length of time afterwards. And we would usually keep seeing these patients in clinic and then just kind of make a shared decision based on how somebody is feeling and how they're doing. Should we try peeling off some of these therapies? Some people have a separate indication to be on certain medications because they have high blood pressure or they have high cholesterol. But if they don't have any of those indications, we like to just make a shared decision. We don't have really good long-term data about what to do. And so that is usually a decision between the patient and the provider.
Got you. Perfect. Would you give us like any valuable tips for cancer patients as they're going through this journey regarding, your specialty, the heart?
Yeah, I think that certainly, asking your oncologist if you are somebody who should be seen by a cardio-oncologist or a cardiologist, it's a good question to ask. And then, just trying to do your best to not only go through all the therapies, but try to maintain an appropriate, balanced approach to the treatment. And that really usually requires getting all of your helpers to be helpful and relying on your family and your friends, because it's such a large emotional toll. And I think, making sure that patients are emotionally well cared for is definitely important as they're going through their journey.
Okay. How about exercise? What is your point of view on exercise with these patients?
Yeah, obviously exercise is helpful. Exercise is important. Exercise prevents cardiovascular disease. Patients who are actively getting chemotherapy, though, oftentimes they don't have tremendous amounts of energy. They can oftentimes have lower blood counts, so they don't feel great when they exercise. And so I think that, that is something that has to be personalized. We would want individuals to try to maintain, as much of an active lifestyle as possible, but that can be really hard during active chemotherapy. And then what also goes along with that is nutrition. That too can be really hard when people are going through chemotherapy, particularly if they're having a lot of nausea or vomiting. How can we maintain good protein intake? How can we keep our muscles well built? And so I think all of that is, requires, that sort of multidisciplinary care, a lot of support from caregivers as well. But ideally, we would want individuals to stay active and to try to maintain a healthy diet.
Are you feeling, how about from the heart standpoint? Like, I have seen some research shows, exercise actually improve enhancement, tumor environment, and it's great for the heart. And then you see on the other hand, some studies saying like, oh, we just don't want to really push the heart too much because we can create even more damage with exercise. What are your thoughts on that?
Yeah, so exercise is universally helpful. I think the only thing to avoid would be like ultra marathoning and those types of extreme types of exercise. Again, most patients who have, getting chemotherapy are not likely to do that, but I think just trying to be active and trying to maintain normal types of exercise For people that want to get a better idea of what types of exercise are recommended, if they were to go to the American Heart Association or the American College of Cardiology, you can see those specific guidelines for what is considered, an appropriate amount of sort of moderate intensity exercise, and also some ideas on what's a good quote unquote heart healthy diet.
Okay.
And then you can kind of adapt that to your own, personal lifestyle and your own culture, your own tastes.
Got you. So that's something that we've been really, and I have seen, I've been doing oncology for maybe 14, 15 years, and it's really nice to see how I went from like, oh no, you have cancer, you take it easy, caregivers just bring their food to their beds, you don't do anything, to now like, no, we want you to be as active as possible. I want you to keep as close as your normal lifestyle, as long as, safe. So, so I have been coming across some patients, breast cancer patients, with a lot of the majority that I treat, and with like they're really having an active style, right? Like they're CrossFitters, they're they run marathons. So it's kind of like, how can we just make sure that, yes, we use a lot of RPs, we just make sure that blood counts are okay, and we just go based on symptoms, but at the same time, it's like, it's hard to keep them into a basic when they already used to be up high level. So I kind of let them train them and say, okay, we're just gonna, based on RPEs and based on heart rate and based how you feel, we may just have to modify a little bit and maybe not as much. So really depending on patient to patient. But I always kind of get like, make sure that your heart is okay. And if the heart is not okay, make sure that, you see somebody like your cardiologist, to make sure everything is good. But so is that okay? Is that okay advice to say to those patients who are high level? Okay, good.
Yeah. I think people who are previously well trained, they're, as long as they're able to do that activity, and if they feel poorly, they can always slow it down.
Yes, yeah. Great. How about the more painful lesson that you learn along the way?
I think some of the painful lessons that we learn along the way is that this is, still a developing field where, people have been getting chemotherapy for a long time. And we've known about some of these cardiotoxicities. And so the painful lessons are just that it's taken us this long to try to figure out how to prevent them. And I would say that those are the lessons that we've kind of learned as a group.
Got you. What do you mean? What does it mean to advocate for yourself, and how can people do that? You want to give them some advice on that?
Yeah, so again, I think, asking if you should be seen by a cardiologist, asking about, potential concerns for cardiac toxicities for the chemotherapeutic agents, and then, advocating on your behalf for, diet and exercise, just as you've discussed. But I think patients should feel comfortable asking, hey, do I need to be seen by a heart doctor?
Okay, great. What other good resources for patients they can use to educate themselves? You already mentioned the American, Heart Association. Is any other good resources that you can advise them to look into that for educate themselves a little bit more about that?
I think that might be, the best one right now. And again, this is a real active area of research. So there's a lot of different research articles that come out very frequently. But I do think that from a global perspective, that would probably be the best resource for patients.
Got you. Is any books that you would recommend to the audience?
So I read fiction, and so
That's
I can. I can just say the books that I'm reading right now. I'm reading two books right now, and one is called The Crook's Manifesto,
Uh-huh.
and the other is called The Center.
Okay.
And so those I tend to only read fiction.
No, that's good. That's a good thing. You don't, sometimes as healthcare providers, we get kind of like involved into all medical, that we don't
Mhm.
get so much time to let's kind of have, let me just change something different that is not
Yeah,
related. And this is including myself. Sometimes it's like, okay, by the time I finally get to do that, then it's like one page and fall asleep because it's already 11 o'clock
yeah.
at night, right? So, but yeah, I'm glad that you're doing something different. How about movies?
I saw Wonka. Wonka is very good. Yeah.
Good. Very good. Is any one question that you wish I would have asked you and will you have answered it?
No, I think you kind of covered it all.
Okay, great. Yes, so I really, I think more patients as I see, sometimes it's like, I just have literally a patient today that unfortunately is a stage 4 breast cancer, and it was given by the medical oncology, like you have these two options, right? This drug that can create cardiotoxicity, this drug that is going to have more issues with your neuropathy that you already have. So it's a lot of like, unknown, like, is how is my heart is okay? Do I want to
Yeah.
take a chance to really damage my heart when I'm already been trying to survive with this cancer for 4 years, right? So it's like, should I just try something that is going to touch my heart first? If that doesn't take care of how the disease is advanced, then let me just try that. So it's a lot of like, what should I do? So I kind of like, I'm so glad that you're able to tell patients, like I feel more comfortable telling patients, if you have some of these comorbidities, for sure, talk to your medical oncologist to get a referral to see you or your department. So those things can start to really evolve better for their own like peace of mind, right? Because it's a lot of like,
Absolutely.
oh my God, now I have to do a test, which, actually that brings me to another question before I let you go. If I know you have to have a base echo or a MOGA prior to it, how soon prior to it will you do that? Like if you have a patient who had it a year ago, is that valid or you have to do something more recent?
I think if that individual's had one a year ago, does not have any risk factors for heart failure, is not having any heart failure symptoms, I think it's okay to keep moving forward. But I think if that individual had some risk factors, then they probably should get an updated echocardiogram.
Okay.
And then depending on their type of chemotherapy that they're getting, they'll get surveillance echocardiograms throughout the course of their treatment.
Yes, this is yeah. And then after that, they continue doing that, right? Isn't that a time?
Generally, yeah. So you would continue doing that perhaps on an annual basis, depending on their age and their other risk factors.
Okay, perfect. Well, you were super helpful. That was really interesting. Thank you for all that amazing value that you just give to the audience. I really appreciate the time that you spent with me.
Thank you. Thank you so much.
Okay, you have a great evening.
You too. Bye-bye.
Bye.